it involves neck nodes. The jugulodiagnostic lymph nodes are involved in 56% of patients. Posterior triangular lymph nodes involved in 22% of patients. Etiopathophysiciology, we saw it can be spread from tonsils, hematogenous spread, and rarely from the Simpson's fascia. The lymph nodes we saw first, the bacteria attacks the subcapsular area, followed by lymphadenitis, periodinitis, the involving the corrective tissue around the lymph nodes, followed by the bacteria attacks the cortex, involving multiple lymphoid follicles causing cold abscess, and then it can involve the medulla of the lymph nodes. Following that, this subcapsular abscess can trickle down deep to deep cervical fascia. It's called as cold abscess. If it crosses the deep cervical fascia, it is called as cholesterol abscess. Also, it can eventually form sinus involving skin if it involves skin. The subcapsular involvement and peritonitis followed by fibrosis causes matting of lymph nodes. The stages we have: stage 1 lymphadenitis, stage 2 matting, stage 3 cold abscess formation, stage 4 cold stud, collar stud abscess formation, and stage 5 we have sinus formation. Pathology we saw on gross, we see firm lymph nodes which are matted. Also, we saw caseating material inside the lymph nodes. On histopathology, we see caseous necrosis, epithelioid cells, Langerhans Giant cells, and surrounding lymphoid cells. Clinical manifestation: patient presents with swelling in the neck. The matting of lymph nodes is firm and matted. The cold abscess can be soft, smooth, non-tender, and fluctuate. The cold stud abscess is differentiated from cold abscess by its adherent to the underlying skin. The discharging sinus can have wide open mouth with undermined edges, and the patient may have multiple tubercles in the tonsils. In case of if the patient has secondary involvement of jugulodiagnostic lymph, we can see the tonsillar involvement. Other areas we can see the features of pulmonary TB and cervical spine TB. The investigation we saw, we do blood examination where ESR is raised. On USG neck, we can see matting and sinus tract. FNAC, we see various cells like epithelioid cells and multinucleated Giant cells. On OPM biopsy, we can see caseating granulomas. For identification of bacteria, we can do PCR, TrueNet, CPNet, or culture using Levinson-Jensen media. The treatment, we have ATT in 2 phases: HRZD intensive phase and HRE in continuation phase. If the patient has cold abscess, we will first aspirate using Z-tract, or else if the patient has recurrent disease, we will do infusion and drainage, followed by, if the patient is resistant to medical treatment, we remove the lymph nodes. If the patient has already formed sinus, we will excise the sinus tract.